This is Going Under, Anesthesia Answered with Dr. Brian Schmutzler. I'm Vahid Sadrzadeh. We're brought to you by the Butterfly Network.
All right, I'm going to let you in on something that's completely changed the way I practice. I've been using Butterfly probes for years. It's a portable ultrasound that plugs into my compatible smartphone or tablet so I can start scanning at the bedside in seconds. If you've used the older versions, or even if you're new to the handheld ultrasound game, let me tell you why this IQ3 is a game changer and really impressive. First off, having an ultrasound that literally fits in my pocket means I can move faster, whether it's vascular access, procedural guidance, or just getting real-time insights from my patients. And the tech inside this tiny device is pretty incredible. Biplane imaging lets me see short and long axis simultaneously, which is huge for procedural guidance and honestly a great tool for learners. The new needle out of plane preset even shifts the scan plane directly and digitally, so I can see the needle tip sooner, which makes a real difference when precision matters. And the image quality, honestly, the IQ3 holds up against some of the high-end cart systems I've used. That's impressive for something this portable. If you're looking for a device that supports your practice, I can't recommend the Butterfly IQ3 enough. And right now, they're running a special offer. You can get the new Butterfly IQ3 for $750 off. Check it out at butterflynetwork.com.
Flawless.
Speaking of Butterfly, I think they were on again on The Pit. The new season of The Pit came out.
Oh, it did?
Yeah.
People are a huge fan of that TV show.
Maybe next week we can talk about The Pit.
That'd be good. Today we're talking about insurance and pressures on hospitals. Do you go into a hospital and it's busy and you think to yourself, man, these guys must be making a killing over here.
Yeah.
It's not exactly that way anymore. And maybe we can talk about how hospitals do make their money these days.
Right.
And what legislators are doing about it to keep hospitals up and running. So let's go back to the beginning here and talk about, how do hospitals get their money? How do they make their money?
Right. So just for a little background, I spent a lot of time in the rural, small hospital, critical access world where there is some federal funding for that, but these hospitals are small. They run on very small margins, and they have to be very fiscally responsible, right? So there's a few things that are happening. All right, so let's go. How do hospitals get paid? So 80% of the revenue of any hospital is coming out of the operating room. Okay, so that's where most of the money's made. No matter what the insurance of the patient is, most of the money's made out of the operating room.
Is there is it based? Sorry, this is just questions for me. Is this based on what does that physician charge per hour, or is this like a hospital fee? They have
a facility fee.
Facility fee, right?
Yeah. So that's more what we're talking about. The procedural fees, like I get paid the same to do anesthesia, whether I'm in an office, whether I'm in a hospital, whether I'm in a surgery center. Doesn't matter, right? So it's not the professional fees. Those go. The only time those matter is if the physician is employed by the hospital system. Then the hospital system takes those professional fees and then uses that to pay the physician.
Got it.
What I'm talking about is the facility fees. The way that hospitals run is they get facility fees. So those fees mostly come out of the operating room. Now, not just the actual cases, surgeries going in the operating room. It's also all the ancillary stuff. So they get paid more to have somebody on the floor staying overnight. They get more for having x-rays and MRIs and CTs and lab draws and physical therapy and all that sort of stuff. So the money isn't fully generated just from the surgery in the operating room, but all the stuff that comes with it. But that's about 80% of the revenue of any hospital. So the hospital doesn't make a ton of money if let's say you have a pneumonia and you go into the hospital. They're not making a lot of money off you coming to the hospital for pneumonia.
Lab draws.
I mean, some, but they're really making a lot of money if you come in for a broken arm, that you have to have surgery on.
X-ray.
Or a total knee replacement like Dr. Adam Cien does, right? So that's where most of the money comes from hospitals. So it gets paid by Medicare, which is typically the highest percentage of payments that hospitals get.
Sure.
Medicare sets the baseline. So, every state administers Medicare a little bit differently, but it's in a pretty tight range of what hospitals get reimbursed for Medicare, whatever, right? So Medicare, whether you go in for pneumonia or you go in for a total knee. Medicaid usually pays even less. Now, it's interesting. In the state of Indiana, at least prior to losing some of the Medicaid funding because of federal things, Indiana pretty much told Medicaid, because we had the money to do it, that they would pay the same as Medicare. So that was a huge boost to a lot of these hospitals. So a lot of small, rural, and critical access hospitals take a lot of Medicaid, just because the more rural you are, the less likely you are to have a high-paying job and all that sort of stuff. So Medicaid in general pays less. Indiana's a little bit better. Then you've got commercial insurance rates. Typically, the way that things work with commercial insurance is they take Medicare, let's say, and I'm just making things up. Let's say Medicare's $100, just because it's easy math. What the insurance companies will say is, we'll pay you 125% of Medicare or 150% of Medicare. And so if you're getting paid $100 by Medicare, you're getting 125 or 150 from a private insurer like Anthem, Blue Cross Blue Shield, Aetna, United, all those companies. Okay. So that's the baseline of where the money actually comes from. The problem is, and now Medicare and Medicaid are less likely to deny, just because they don't have a big financial incentive to deny care. The private insurance companies deny a lot, right? So they have people
that's Blue Cross.
That's Blue Cross. That's Aetna, United, Cigna, all those companies. They get paid. They pay a multiple amount of people to go in and try to make sure that they deny cases, right? They look for things, any little thing on there that they can deny the case. Well, because they're companies that have shareholders, so their whole job is to make money, not to make sure that they're paying for.
But don't they know
care.
that? I mean, eventually that's going to shut hospitals down, and like people are not going to be able to afford care.
Yeah. But do you think the shareholders care about that? No, they don't care about that, right? Why would they? All they care about is what they get in their pocket in the next dividend. So
that's insane. I mean, whatever.
So here's the other thing, though. Insurance companies, particularly the private insurance companies, again, less so Medicare and Medicaid,
sure,
are forcing more prior authorizations. Meaning that if I say, "Oh, Vahid, your knee is terrible. You need to come in and have a total knee done," a lot of the private insurers will go, "Well, no, we're denying that. You have to do 6 weeks of physical therapy." Oh, you did 6 weeks of physical therapy, but you didn't try an injection of steroids. So you're going to have to do that and wait another 3 weeks. And then, we're still denying it because, you can't prove to us that you lost enough weight to actually be a candidate for the total knee. And then, now you lost the weight, but, we need to get another x-ray because your x-ray is too far out of date now. Yeah. So it's a game that the insurance companies play. And then, if they, by some chance...
Does this happen with dental places too?
Yeah, they do. Although the dentists are brilliant, because what the dentist did is they said, we're not taking anything ahead of time, right? We're going to charge you ahead of time $1,000 for your crown. Your insurance company might pay you back some, but I'm not, as a dentist, they're not taking any risk, right? So they've got your $1,000 in hand, and then your insurance company will pay you back whatever they think is fair.
Ooh.
Right, so you pay $1,000 for a crown.
Right.
They'll pay you $400 to say they think your crown's worth $400, but the dentist has already got your $1,000. Right,
Boy.
It doesn't matter. So
that's a dangerous game for people.
Correct. Here's the other thing. No, so let's say they authorize you. They're going to pay, right?
Yeah.
So they're not denying it. Then they just hold back the payment because these insurance companies say, "What are you going to do?" Right? So there's an insurance company here in northern Indiana that several of the people that I work with, they were behind in paying them by 8 months. They just said, "Yeah, we're not paying you right now. What are you going to do about it?"
8 months?
8 months, yes. So, but there's nothing you can do about it. There's nothing written in law that you can fight the insurance companies about this.
Does there need to be?
Oh, 100%. Yeah. I mean, so this is something, and we don't, generally talk a ton of politics on here, but we'll talk a little politics. In Indiana in particular, the legislature has gone after hospitals a lot. There was a thing called the Rand report that came out 6-7 years ago. 6-7 years ago that
as my 12-year-old said, yeah, Brian, that's so last year. That's so last year.
So the Rand report came out and said that the big five in Indiana, and I won't name them because I don't want to slander anyone, but the big five are the most expensive in the country, blah, blah, blah. And the way that the Rand report was flawed in many ways, the way they did it was not perfect, but cost of care, at least in perception, is high in Indiana. So the legislature has been just slamming hospitals. And I'll tell you what that's meant is that hospitals have either stopped doing certain services, particularly obstetric services. There's tons of hospitals that we service in rural and small communities where they say, we're not doing OB anymore. You've got to drive to Fort Wayne. You've got to drive to South Bend.
Well, I was going to ask you that question, too, because that seems where a lot of hospitals make their money,
No,
too.
not OB. No, obstetrics is a money
Really?
loser. Yeah. Because it's mostly the procedure of a vaginal delivery is not paid well. It's not a
So
surgery.
even when they stay overnight and use the cost of this thing?
So they bundle it. That's what all these insurance companies do, including Medicare and Medicaid, is they bundle, like, okay, you're going to come have a baby.
Sure.
And here's your bundled price. And so it's not a moneymaker. It's a service to the community. Obstetrics is almost always, I can't think of a single hospital that I've ever worked at or ever had any association with that's making money on obstetrics.
Got it.
Yep. So they're cutting that service first. Then they're cutting call services. So we have a bunch of hospitals, again, around Fort Wayne and around South Bend, where they said, we're not doing call anymore. It's too expensive to pay people to come in. We're not getting reimbursed enough. We've become a day surgery hospital. So they have patients upstairs that are dealing with medical or whatever, but we don't do emergency cases at night. If you have an emergency and you come into our ER, we're sending you to Fort Wayne or we're sending you to South Bend.
So if I'm starting a hospital today with Dr. Brian Schmutzler,
Yeah.
First of all, is it a good idea?
No, definitely not.
Surgery center, better idea?
Maybe. But that's getting cut too now.
If you start a hospital here, what is the one thing that I cannot not have in a surgery center?
You have to have surgery.
You have to have
surgery, right? You have to have operating rooms, and you have to have efficiently functioning operating rooms.
And if you don't have that,
then you're typically going to lose money. So then the next step is, after you've eliminated the services that don't make money, which is like obstetrics, and then you've eliminated call, like, so you don't do anything at night, then you just shut down as a hospital, right? So it gets to the point where you just aren't able to do it anymore. And so I guess what I'm saying is, our legislature has taken a swing at the hospitals and has really put a lot of pressure on them about cost. I think what they've missed is that most of this pressure is actually coming from the insurance companies, because the hospitals have to make money. They have to make money on top of what they would have gotten paid from the insurance company, because they never know when they're going to get denials and prior authorizations and, delays in payments and stuff. And so they have to charge more. And Indiana, and I would argue that one of the big reasons why Indiana hospitals are so expensive is that the largest payer, non-government payer in the state of Indiana, is Anthem, which was a combination of two medium-sized insurance companies that joined forces and became a gigantic insurance company. And their rates are atrocious. Their denials are atrocious. The amount of delay in payment is atrocious. And so that's probably 60% of the private insurance in the state of Indiana who's not paying the way that they should. So of course the hospitals are saying, well, we've got to be able to survive here. So what are we going to do? We're going to charge more money so that people with insurance or people who are self-pay are covering all those losses from the people that they're not getting paid from by particularly Anthem.
So you're looking at, like some of the, old clinic looking facilities, right? And I mean, not specific ones. I'm just saying, like, that general modality can't have that anymore, essentially.
It's hard. It's hard anymore. Yeah. And so then there's all these like mergers and acquisitions and
you cut staff, right? I mean, like,
yeah, but then you're merging hospiel systems, right? So there used to be, so if you talk, there's one of the bigger systems in the state that's going and buying up hospitals. Now, I'm all for these hospitals surviving, but you're also eliminating competition. I'm not saying it's the wrong thing to do, right? It's close the hospital or get purchased by a bigger hospital system. But by eliminating competition, you're then actually driving prices up, right? So,
absolutely.
Right. So it's going to be a tough balance, but I get why hospitals have to do it, because there are certain communities that if a bigger hospital system didn't buy out the hospital, they wouldn't have a hospital anymore. They would just shut down. Mm-hmm. So,
but it's rare to find independently owned
hospitals
and clinics anymore. I mean, this just doesn't happen.
Yep. And then what do you want? Do you want them purchased by a big system in the state, or do you want them purchased by private equity? Because there's a whole set of hospitals in our state that are owned by
Private equity?
By private equity. Well, they're a for-profit system, so there's some outside money in there. I don't know that they're fully private equity backed, but there are hospitals in our state that are for profit, which is bad for I'll be honest. The for-profit hospital systems are bad for everybody.
So this is a two-part question.
Yeah.
If this is happening, what are you seeing? What can you do as a patient? What are you seeing? What can you do as a physician?
Not much.
On either side.
No, I mean, this is going to become a legislative matter. I can't fight the insurance companies as a physician, and you can't fight the insurance companies as a patient. I don't know what to do about any of this. Unless we just band together and do, like we've talked about before, direct-to-consumer care. So you work for whatever, let's say a RV company.
Yep.
Right? You work for an RV company. And the RV company contracts directly with a physician group. Make it up. Nuco Physician Group.
Sure.
That RV company contracts directly with that physician group and directly with the surgeon group and directly with a hospital and says, okay, I'll pay you X amount. Give us your fee schedule. We'll negotiate that directly, and I'll pay you X amount. And then there's no insurance company involved, right? So then who you're dealing with is the director of HR for your RV company instead of some distant CEO of an insurance company. So that's maybe the only way to do it. A lot of primary care physicians are going to DPC, which is direct primary care, where they say, I don't take insurance at all.
Right.
No Medicare, no Medicaid, no insurance.
And
you pay me cash.
That's the concierge medicine.
Yep. Yeah.
So in general, as we kind of review and put a cap on the conversation, what can be done in the state of Indiana? What can be done nationally? This puts a lot of people in a tough spot.
Yeah. Yeah. I think if you generate enough support to push back from a legislative perspective on the insurance companies, and I have some ideas, but I won't share them here, of how we can do that. I mean, there's been a couple of states that have pushed back on the insurance companies and said, you guys are a monopoly. And I mean, honestly, they're practicing medicine without a license, right? I know they have a little clause in all their contracts that says you can still have this done, we just won't pay for it. But when you're talking about somebody who has to have $100,000 of care done and they make $50,000 a year, they'll never be able to afford that. So they really are forcing people to not get the care they need, and that's practicing medicine without a license. Period. So
tough.
Yeah. So and I don't want to be all doom and gloom. There are some good ones out there. They're in particular, and I have no tie to this company whatsoever, but just doing research in the state of Indiana, PHP, which is Physician Health Plan or something like that. They're kind of a local company. They're not for profit. They're in it to make money, but they don't seem to have the same level of just pure hatred for their for their subscribers that the national and even the big ones that aren't technically national but are have. So like if you're looking for a health plan, if there's something a little bit more local, like here in Indiana, PHP, maybe that's the way to go. Maybe we get away from all these Blue Cross Blue Shield, Anthem, United, Cigna, Aetna, and we go towards some of these companies who are actually in the community. But otherwise, it's going to have to be something where we just eliminate them completely.
The debate wages on with the insurance companies.
It does. But I do.
It seems endless, honestly.
I do want to make the point that I don't think that continuing to go after hospitals, whether or not you think there's some bad actors there, is the right thing to do. Because if you keep going after the hospitals, all you're going to do is shut them down, and then people don't get care, right? So we have to have hospitals. Good or bad, we have to have hospitals. We have to have physicians. We don't have to have insurance companies. We can figure out a way to survive without insurance companies who provide really no value to the system and take a lot of money out of it. So I would caution anybody from getting too mad about a hospital or a physician about the cost of care. The cost of care is coming a lot from those insurance companies.
Well said. I'm gonna end it right there because I'm not going to say anything that trumps that. This is Going Under, Anesthesia Answered with Dr. Brian Schmutzler. I'm Vahid Sadrzadeh. And we'll see you in the next one.
Sounds good.